International President of the Sami India, to say something about you. Hello. I will request Dr. Milind Chaudhary to speak on the lengthening. Please come.
Start.
Yes, sir. उनका तो लैपटॉप उधर लेते हैं हॉस्पिटल पे, उनको ही विल कनेक्ट हिज लैपटॉप, ठीक है मैम, तो इधर लेते जाओ सबको डाल,
सारा भी डाल देते हैं पोडियम में डाल। हाँ
लग ही जाता है, यहाँ नहीं लगता मेरे यहाँ।
इसमें नहीं है,
इसमें नहीं आ रहा है, ठीक ठीक है, इसमें नहीं आ रहा, मेरे इसमें नहीं आ रहा, चक्कर है बड़ा। कोई बात डोंट वरी, शुक्रिया।
I will request the chairman, Dr. Dimitri, please, and Dr. Gobin. Yeah.
Mr. Charles Carver will be the first. Thank you. Okay. Yesterday lecture.
Yeah, lengthening is there. So it is lengthening.
Okay.
No, this is important. Original here. So this image of
Okay.
number 4, Dr. Junjunwala, STU. STU.
So Mr. Charles Carver will present his first lecture about limb lengthening.
Thank you. Mr. Chairman, sir, Professor Alexander Gubin, Professor Dmitry Berzunov, Professor Mufakharul Bari, and my dear friends. Thank you, Dr. Agarwal, for kindly giving me the opportunity to continue the talk that I missed yesterday. I'll be brief. Dear friends, this is going to be a small talk on limb lengthening. And of course, we know that limb lengthening is the basis of many of the reconstructive procedures we do in ilizarov. Even if it's an infected non-union and we want to fill up a bone gap, do bone transport, the principles of limb lengthening will come in handy, even if you don't want to do limb lengthening per se. So just a few things. Measurement of limb length. Clinically, if the difference in limb length is significant, then you can obviously see with the Galeazzi sign if the femur is short or the tibia is short. But if the difference is subtle, say 2 centimeters or less, or 3 centimeters or less, very frequently, unless you use radiological help with a scanogram, which is taken on a bucky with 3 exposures, especially if you have a fixed flexion deformity of the knee, you can make an error. Especially in poliomyelitis, you can end up lengthening a limb which is not really short. And this way you can come to know whether the shortening is an apparent shortening caused by a scoliotic list with a pelvis which is high riding. And fixed flexion deformity is compensated by keeping both the knees in the same position, okay? So then you come to know accurately whether the shortening is in the femur or the tibia. If there is no contracture or deformity, you can take a full length X-ray like this, which tells you if the shortening is in the pelvis, in the femur, in the tibia, or in the spherion, which is the zone between the malleolus and the foot. Once you know the most important thing is to know the 7 golden rules of limb lengthening. They were elucidated by Professor Gavril Ilizarov, and they have been very nicely described in the English article in Clinical Orthopedics Related Research number 230 of 1990 or 1991, if I mistake not. If you have access to that journal in your library, make all efforts to try and read it. If you have the patience to read that article in its entirety, I promise you, you will understand limb lengthening like no other article, lecture or demonstration can. So the main principles, the first principle is stable fixation. You need to have stable fixation without which bone cannot form. That's the fundamental basis. Whenever things are going wrong, all you have to do is go back and check for stability. If the stability is missing or wanting or deficient, you must add to the stability. Simple steps are tightening of the connections, addition of connections, addition of a connection to a half pin, addition of pins, so on and so forth. And it depends upon the weight of the patient, age of the patient. So you get stability. Stability is the key, You cannot emphasize enough. Without stability, you achieve nothing. And you must understand, get a sophisticated understanding of how stability affects the process with any ilizarov that you do. Okay. Next is atraumatic corticotomy. Try and do it as atraumatically as possible with a tiny incision. Try and not damage the periosteum, which is absolutely the key. The third is the latency period, which depends upon the age and the indication. If you have an adult who's 55 and you did a corticotomy which is not very, very gentle, and if it's, let's say, in the little bit in the diaphysis, I would strongly recommend you wait until 15 days to start the lengthening. But if you have a child who's 3-4 years of age and you've done a good corticotomy, you can start distraction on the 4th day. So you can take a judgment call. The rate of distraction is typically 1/4 mm 4 times a day to give you 1 mm per day. And you can vary this also in, say, poliomyelitis or in a smoker or in an elderly person. You can go at 1/4 2 times a day. And the rhythm of distraction is, whether you go 2 times or 3 times or 4 times a day. Or, if you want to slow down the lengthening, you can go at 1/2 mm 2 times a day or 1/2 mm once a day. But if you want to improve the quality of the regenerate, you have to go at 1/4 4 times. And that's the principle of the automated distractor. You can go at 1/60th of a millimeter 60 times a day. That's what the automated distractor does. And that gives you the finest quality of regenerate. And then you have to preserve the vascularity and, most important, preserve the function. And I must not forget to add, you must preserve their occupancy, that is the ability to work, especially for housewives. They need to get back into the kitchen. They need to look after the other members of the family. They should not be dependent, and men, folk must be able to get back to work. If you do these, you will be rewarded with good results. Now, corticotomy can be of 3 types. You can have the classic corticotomy, which is what they do in Russia, which is what I learned, which is what I love. But that you can use very nicely only if you are having all wire fixator. Okay? You just take a 5 to 6 millimeter osteotome and then go through the anteromedial cortex in the tibia, the anterolateral, and then do a rotational osteoclasis maneuver to fracture the posterior cortex atraumatically. But if you are using half pins, which most of us are using these days, because they're so good, we use a drill hole corticotomy. We make multiple drill holes, they create stress risers, and then you connect them with your osteotome. A jiggly saw osteotomy was designed by Dr. Vardak in Kabul and was picked up and popularized by Dr. Paley. And this is a very nice osteotomy, but it of course damages the endosteum. And you can use it very nicely when you have a short fragment for bone transport. That's its real indication, but you can use it in many places. Now, the 5 essential questions this talk is going to be based on this is: why to lengthen, how to lengthen, which segment or which hardware to use, where to lengthen, and when to lengthen. So why lengthen? This, why lengthen is, even with a discrepancy of 2, 3, 4 centimeters, you can have a curvature in the spine, you can have more forces on the other joints, and the patient can suffer osteoarthritis in the other joints or backache later on. So the mechanics of walking are improved, especially if the person has polio. Then with additional muscle weakness, the amount of forces borne by the other joints are significant. So you have to do them a favor by trying to go nearly equal, okay? And it always helps. Upper extremity, not so important. Lower extremity, limb lengthening is now a standard procedure. So you can do proximal tibial lengthening, very nice regenerate. You can see the patient is allowed to walk, and it's most important. and the energy cost of walking goes down, especially if they have polio, etc. So how to lengthen? Now I'll refer you back to the 7 golden rules. That's going to give you all the information you need. But still, how to lengthen is this child 15 centimeters shortening in the humerus, and here you can use a hardware like the LRS fixator, or you can use the ilizarov also. The LRS, the benefit is that it is easy to manage, but the ilizarov, the tremendous benefit is you can put in half pins from the medial and the lateral side, and you have really good fixation, okay? And you can angle your pins in different directions. So ilizarov is really, really the most universal fixator. Honestly, believe me, there's nothing better than the ilizarov. However, some patients are fussy, so you can do the LRS, do a percutaneous corticotomy, achieve length, which she got slowly 14 centimeters in this manner, and yet you manage to retain the function in this fashion. You can see these are just pin tracks, and the scars will go away. You can treat them also. Now, you can also perform really tough ones like lengthening and rotational correction. How to lengthen? So we do a distal lengthening over here. We lengthen and we gradually derotation, do the fibular osteotomy, fill up the gap at the upper level by inserting a fibula, and give the patient a straight limb with 10 centimeters lengthening. So, very rarely you will have only lengthening as a task. You also have to perform a lot of other things. And, this is actually on which hardware to use. So when you have somebody with 9 centimeters of shortening like this with polio, it can really take a long time. So you can do a lengthening over a nail. This is a humerus nail locked above, kept free below, and then you use the ilizarov fixator with just 2 wires over here to do the lengthening. As soon as the length is achieved, the nail rides up, you have this gap, you can lock it, and then put him in a brace or a plaster, and then the bone hardens nicely, reduces the fixator duration. It's so much easier for the patient. It's especially important in the femur more than the tibia. And here he is with his result. X-pic comes out soon. Now, which hardware, like I just said, you have to weigh the pros and cons and become familiar with each. Each has its strengths and weaknesses. The ilizarov has all strengths, and the only weakness is the amount of time that you have to spend learning, all the the tricks that it can play. So this gentleman with a lot of shortening, post-traumatic, you can see a non-union here with a nail shortening in the tibia. So we choose to perform an LRS fixator. This is LRS gives you compression at this level, lengthening at the upper level. It's more convenient for the patient, especially because he's having tibia and the foot frame as well for deformity correction. And you lengthen the tibia with a circular fixator. The tibia is really nicely dealt with the ilizarov because it's circular, because the tendency for valgus anticurvation deformities are not very well controlled by the LRS fixator, especially if you want to do a long lengthening. So you choose judiciously, you can choose judiciously. Because the femur lengthening is not much, I prefer an LRS here. But if you want to do a long lengthening, the LRS fixator pins are all in one line, so they tend to tether the quadriceps, and you can have a lot of knee stiffness. So you must be aware of the strengths and weaknesses of the different fixators. So this gentleman got all of his length, he got his femur to unite, the tibia also lengthened, and is perfectly equal in a reasonable time period. Now, which hardware again? Let's take a look at this boy who has 16 centimeters shortening due to growth arrest. You can see this. He's got deformities in the tibia here, varus here, significant varus here. Not much varus here, but you can see. Now you want to retain knee function. You want to break up this 16 centimeters into 3 lengthenings. So I choose to perform lengthening over a nail in the femur. This is a straight nail, specially designed. And you see what's happening at the lower femur, you can't insert it from here. So you insert it from the proximal end like this, and you lock it. I locked it distally because I kept the nail long over here because I didn't want the pins to come too close to the nail. And then we went ahead and did about 7 centimeters of lengthening. You watch over here in the femur like this with the fixator. The nail which was over here has come down, but the varus deformities and lengthening are very nicely tackled with the ilizarov because there's also an element in the sagittal plane, and the ilizarov is wonderful for the tibia. A very good correction of the varus over here, lengthening the mechanical axis is in the center, and you're rewarded with a good result with retained function. So that's the key. The LON can help you. See, if you give them a lot of length and the knee is stiff, they're not going to be terribly happy, not in India. India is not a disabled friendly country, you know that, okay? And even traveling by buses and trains, if your knee can't flex, you're miserable. People are tripping all over you. So really, now where to lengthen? Where in the bone? Now this child from Saudi Arabia, very significant deformity due to posteromedial bowing. Obviously at 45 degrees, you need to lengthen him at the apex of the deformity. And which is what we did. We lengthened him over here. And the region rate was a little poor, but we had to stop short at 3 centimeters, and he did get good bone and consolidated, which was straight. In the next stage, when the limb is straight, after 4 years, we can perform the lengthening at a proximal corticotomy like this. And then this is again taken 3 years after this lengthening, and then give him a second bout of length. So where to lengthen is you choose the site as metaphysical as possible is ideal. Now this girl with a forearm shortening, radius is shorter than the ulna, the forearm is shorter than the other one. So you need to lengthen both of them. Now where to lengthen? Now the trick is to have separate rings for the radius and ulna. Use carbon fiber and titanium pins to make it light. The radius is lengthened at the distal metaphysis, the ulna is lengthened at the proximal metaphysis. Both the areas are wide, they reward you with good bone formation, and you can go ahead and get almost 7 centimeters lengthening in the radius, 5 in the ulna like this, and you're rewarded with a distal radioulnar joint which is perfectly congruous and function which is retained in a short time. Now if you have congenital pseudarthrosis of the tibia, which I have done now 51 by now, which is one of the largest personal series of a single surgeon. I'm a single surgeon, I work in a very small institute, but I'm doing this for 24 years. When you do this congenital pseudarthrosis and you need to do lengthening because of the shortening, you have to perform the corticotomy, watch over here, at a very high level, subphyseal. That's where again a jiggly saw comes in handy. Because the moment you go down into the diaphysis, the very high risk that you will end up with poor region rate or even a non-union. And that's happened to very, very big names in India, The congenital pseudarthrosis, really be careful. And very proximal lengthening. Then we do the other things, put in a nail, a bone graft, periosteal graft, compress nicely, foot frame. You have to do everything because these are tough ones, multiply operated. And you can be rewarded with a good result, good lengthening, 4 centimeters healed very early. Now, if you have a deformity like this, fixed flexion deformity in poliomyelitis, so you need to perform, say, 3 centimeters lengthening. He's also got this. So you need to, if you lengthen and do the supracondylar osteotomy at this level, then the lengthening takes a long time to mature in your fixator, and you can get knee stiffness. So it's better not to lengthen in the distal femur in polio. So we've done a supracondylar osteotomy here. There is an LRS fixator behind the nail. The nail is inserted distally. It's locked in the middle. Proximal corticotomy is for lengthening. That is kept free. The LRS does the lengthening. And you can see eventually the supracondylar heals up. So does the lengthening zone. And you have gotten rid of his hand to knee gait as well as given him length with retained function. Now question is, last question, second last, when to lengthen? Now with a caveat, of course, this is an advanced course, so please take whatever I say with a pinch of salt. If you have sufficient experience and if you've been doing this for a long time, if you can keep your patients free from pain, if you can keep them mobile, if they don't have complications, then in certain select indications, if the patient demands it, like in this congenital posteromedial bowing, I performed lengthening at 15 months because the father demanded, why can't you do it today? Because it's obviously going to become very short. And we know by the multiplier method that whatever amount of shortening is present in boys at the age of 4 years is going to double at maturity. So at 1 year, the shortening is almost 3 centimeters. So at 4 years, it would have been about 7. So you would have had 14 centimeters shortening at maturity. It's difficult to do too much at a time. So we did, we did the lengthening 3 centimeters, and if you can keep the frame stable, the children can be very happy and play about only 2 days of immediate post-op pain. But again, as I said, this is a caveat. Do not attempt it in young children unless you have a lot of experience. And you don't want the child crying all the time. That's a nightmare for everyone. So don't let that happen, but you can be rewarded with a good result, and then you can do a second lengthening later. So keep each lengthening small rather than attempt too much at a time, you see. Keep it small. And in congenital short femur, when to lengthen? Now watch this hip over here, the acetabular dysplasia is present. So better, before starting to lengthen, you can see she's very short. Before starting to lengthen, perform a Degas acetabuloplasty. It's a preparatory surgery. So when to lengthen? After preparatory surgery. And then then simultaneously we did a tibia lengthening. And then in the second stage, we performed a femur lengthening. Because now there is a little risk of the hip dislocating. Because congenital cases, be very careful. Don't be a cowboy. Don't try to attempt a lot of lengthening in congenital. Be very careful. They're the ones that have maximum complications. Yeah, so second stage femur lengthening. Then she grows up. She's 11 years of age. She has full knee function. She can dance. And in the third stage, we do a third lengthening. So, we have totally lengthened her 15 centimeters and she still has 1 or 2 centimeters to go. So how much to lengthen is the question. If the child comes to you with about 6 centimeters shortening, we can lengthen in the femur and the tibia, and because we are only doing 3 and 3 at this age, we can lengthen a little bit more if it's easy. If the going is easy, lengthen a little more, because in the future he'll have some shortening. So which is what we did. You can see the knees in fixed flexion, a little bit of flexion, which shows that this leg is a little longer. Watch the full length X-ray. That's only if it's possible. Now, how much to lengthen in achondroplasia? You need to give maximum. You cannot give 4 or 5 centimeters and be happy or expect the patient to be happy. We need to do, for example, this doctor's daughter is achondroplasia, is the commonest form of dwarfism. And we did a cross lengthening, femur single level 10 centimeters, tibia double level 12.5 centimeters. Okay, here is the regenerate. Typically in achondroplasia, you must have excellent regenerate formation. There's no excuse for a poor regenerate in achondroplasia. Do not attempt this until you're very, very experienced. And you can get, the first side is over, then we do the second side, and then we do the humerus to equalize the body proportions. And here she is rewarded. Here she is with her father. She's a medical student now and with excellent function. And she also had plastic surgery to improve her nose, the facial features. And you can perhaps change their life. Very finally, again with a very big caveat, how much to lengthen, just as out of interest. Sometimes, rarely I do this. He's a software engineer from Bangalore, works in Canada. He's very educated. Throughout the entire treatment he was studying, he brought his entire library of 50 books, and they follow instructions. I do it only for intelligent people. And we did 5.5 centimeters of lengthening like this, no axial deviation, which is very important, and fully retained function. So the key in limb lengthening is to think about function. Do not go crazy after the amount of centimeters that you need to lengthen. And remember function, and always thanks be to the great man who started it, and I always thank the great Kurgan Institute for continuing to be a beacon of knowledge for the world. Thank you.
Any questions to Mr. Chaudhary?
Yes, sir.
I'm Dr. Bari from Bangladesh. I've got only 3 questions to you. Regarding the LRS, you're putting a lot of shunt spins. Don't you see any refracture in that area? This is number 1 question. Number 2, regarding the CPT, congenital pseudoarthrosis tibia, what's your opinion regarding the ideal age for doing for surgery? And number 3rd question, I have seen in your picture, you have put the nail for lengthening or for union, and how long you keep it laid in the tibia? That's right.
Very interesting questions. The first question is about refracture after using LRS. Fortunately, I haven't had it so far, but you can have refractures because the thing you have to remember is when the pins come out and they're in the diaphysis, in the diaphysial pin, that hole takes about minimum 6 weeks to fill up. Till such time it can work as a stress riser. So whenever I have any half pins in the diaphysis, you remember to tell the patient to be very careful for 6 weeks to protect his lip. That's the key. The metaphyseal hole does not create a stress riser, but the diaphyseal hole, you tell him be careful. Use a walker or a pair of crutches, or don't run after buses. Don't try to go by public transport. That's what I tell them. Don't squat, don't run, don't go in public transport for 6 weeks. Because if they have to catch a rickshaw, catch a bus, catch a train, catch a flight, they are running, they'll fall, they'll break. That's the key. The second question is about congenital pseudoarthrosis. Age. Minimum age for surgery. Here again, I cannot say this as a recommendation because to everybody, but to experienced surgeons. I think, sir, once you learn how to master the fixator, then you have to understand the natural history of the disease. So, sir, many times we don't have a choice. Patients come to us who are already operated upon. But when we do have a choice, if the child is too young and the parents are not in a psychological framework to have the child operated, I keep the child in a brace until the child and the parents are ready. Many times you can see that the parents are ready the child is ready. So you can treat them early also. Because what is the point in waiting? Because literature says a lot of things. But what is your experience? So my experience is that I can start early and gain reliable union regardless of the age.
At the age of
Yes.
1, 2, 3.
Sir, I analyzed my cases. Congenital pseudarthrosis, 51 cases I have done. Actually, it's 53 now. I have a large number of patients below the age of 5 years. Very large number. And I calculated my complications and refracture rate. I found that the age between 5 and 12 years of age, I found a lot of complications. But not below the age of 5 years in my hands. So I cannot say this is a recommendation for everybody. I was not this confident 15 years ago. Since last... Sir, minimum age, if you have the confidence, sir, I have started at 1.5 years of age.
We found that below the age of 3 years, when you take the fragment, something, they cut two of the wires.
So that can happen if you have a lot of movements occurring. But if you don't, if you open it up and if you give immediate stability and if you don't have a lot of movement going on, then that will not happen.
You can check the movements.
What I'm trying to say is if you do a wide resection or if you're trying to transport a fragment, then you have these problems.
At the age of 1 or 1.5 and 2, if this pseudarthrosis, the lower 1/3, it is very difficult to manage. What Professor Vladimir Shipsov, he taught me, don't go beyond 5. You will get lot of complications. And after 5, 3, literature, Takjian, he is suggesting go after the 3, after the 4, and you will get good result at the age of 6, 7, 8, 9, 10, 12, 13. This is my experience, what I am telling.
I respect Professor Shepsov's opinion. I respect your opinion. The only thing I can say is what a famous professor from Los Angeles said. Sometimes technique triumphs over reason. Technique triumphs over reason.
Yeah, I asked with the Professor Dimitri, school ka age, इसका होगा
По хондроплазии с 6-7 лет начинают, ну да, получше.
Yes, usually in chondroplasia we begin at 6-7.
no pseudarthrosis tibia.
Congenital pseudarthrosis.
С 4 лет.
From the first years, from 4 years old.
4 years. Okay, thank you.
And regarding that name,
Regarding the nail,
for CPT,
for CPT, yes. So many times you don't have to worry, it comes off on its own from But if you are able to lock the nail and you keep it for as long as you can, because if the nail stays in place, that's your insurance policy against a refracture. One of your insurance policies. The most important insurance policy is widen the area of union. So, you do a lot of things to do that. And you don't rely on transporting fragments. That's one thing I've given up 20 years ago. Don't transport fragments in CPT. You achieve primary stability on the side. Achieve primary stability at the non-union side and start giving compression. And then keep the nail for us. Widen the area by bone grafting. Widen the area by bone grafting. And by other methods.
Okay. So, Mr. Grawal, you will be the second speaker, please. So, Mr. Grawal will speak about Perthes disease. Instability hip, sorry.
Mr. Chairman, Co-Chairman, my topic is the pelvic support osteoarthropy in unstable hip. Most of the orthopedic surgeons, they are leading the cases of the septic arthritis hip, poliomyelitis, dislocation hips, very common problems we teach everything. So we have done a lot of work on this subject and we will show you how you manage these cases. Fracture neck femur, old fracture neck femur. Now what are the causes of the hip instability? Congenital dislocation of the hip, septic arthritis, osteomyelitis of the proximal femur, avascular necrosis, coxa vara, fracture gelatogentor, slip femoral epiphysis, neurogenic problems, the poliomyelitis, meningomyelocele, failed hip arthroplasty, that is aseptic and aseptic. These are the common causes and we deal every day. Before we start our treatment, we should say there are certain tests for the stability of the hip. We should see whether the hip is stable or unstable. Straight leg raising test, Trendelenburg test, Barlow's test, telescopic test, and Arthur-Lennox test. This is a Trendelenburg test. The patient walk on particular hip there, drop there. This is the Arthur-Lennox test. We separate that. This is the Barlow's test. Now, first of all, this is a very tough subject and very strong biomechanics. We should show what is the technique of the technique suggested by ilizarov accessory consists of two separate osteotomy. Mind you, there is a two separate osteotomy and we should have a very clear concept where to do the one osteotomy. But they all are combined. First, the pelvis is supported by osteotomy in the proximal 1/3 of the femur. This consists of the medial angulation of the diaphysis that places the proximal limb of the femur in maximum adduction in relation to the pelvis and distal 2/3 of the femur in relative abduction. Now there is second osteotomy. Is an additional corticotomy made in the distal metaphyseal area of the femur. Through this corticotomy, the limb may be progressively lengthened according to the concepts of the ilizarov, thus eliminating the leg length inequality. Finally, by producing the gradually varus angulation through this distal corticotomy, the mechanical axis can be normalized through the hip, knee, ankle. In the last, hip, knee and ankle should be in the same mechanical axis. Preoperative planning for the proximal femoral osteotomy. How much valgus you need, that is most important. The amount of valgus required at the proximal osteotomy can be determined by two criteria. The maximum range of passive adduction can be measured by taking the spine radiograph with the affected leg maximally crossed over the opposite thigh. The actual maximum drops angle during single leg stance can be measured by taking single leg standing radiograph without support. The valgus amount can be, the valgus angle should be the single leg stance drop plus 15 degree over horizon. The level of the proximal osteotomy, we added the leg, affected leg, is at the ischial tuberosity level as determined by the cross leg radiographs. Now I am telling you the details. For example, this is the unstable hip is there. We have measured these angles. Now what happens? Number one technique is that we do the adduction of the leg. After the adduction of the leg, we take the X-rays. And by that we make our angles. For example, this angle is 40 degree and this is a 15 degree. So we will add 40 plus 15, that is the 55 degree. Now another technique is that we tell patient to stand. There are two ways. We do the by X-rays and this will help you do the during surgery by image intensifier. Second technique is that the patient is standing particular leg like this. So what happened, as the Trendelenburg is positive, so the pelvis will drop here, like here. So we take a long X-ray, standing X-ray, and we will measure a line here, a line here. So after that what we will do, we will take measure from here to here, this center of the knee joint, and then center of the knee joint to here. So it comes same 50 degree plus and 40 degree. So we will add 40 plus 15, that is 55 degree. That will be our abduction angle. So we will operate that, we will make the planning for that. Now the question arises, distal pulmonary osteotomy is done where the proximal axis line means the line perpendicular to the horizontal line of the pelvis, passing through apex of the first osteotomy, coincide with the distal line, the mechanical axis of the tibia. The femur should be lengthened first without angular correction. The femur should then be visualized through the lengthening zone. The final mechanical axis is perpendicular to the horizontal line of the pelvis. For example, where to do the second osteotomy? We will measure a line over here, and after that it is the osteotomy point. We will make this line straight over here, and then through the mechanical axis line over here where it cuts, bisect through each other. So here we do the second osteotomy. That is very standard. But in Indian scenario which I have got, it is difficult because it should be done 4 to 5 centimeter. It comes 4 to 5 centimeter below the proximal osteotomy. So we do a little later because in diphysial the regeneration is very poor. So we do at the junction of the lower third and the middle third. For example, this is a girl, her Trendelenburg is positive. See, you can see here, she was having the old septic arthritis of the hip. It is his movie. You can see that shortening plus Trendelenburg gait is positive. Now you see that in the early childhood she has got the septic arthritis of knee, and her hip, there was a dissolved, the whole thing was dissolved. So we have applied the osteotomy over here, 2 rings, 1 ring over here, 1 ring over here, and one arch over. This is the configuration of the frame. This is for the lengthening at the distal side, and this is for the proximal osteotomy. This thing is clear to all of you? Where to do the proximal osteotomy? If you have any confusion, you can ask me, because this is a very important for the pelvic support osteotomy. So you see that this is the level of the ischial tuberosity here. So we have done the proximal osteotomy over here. Now second osteotomy we have made a little at the junction of the lower 1/3 and the middle third of the femur. So this was the second osteotomy. This way you can see that very beautifully. It is just level of the ischial tuberosity. This thing is clear to all of you. First osteotomy where? At the level of ischial tuberosity. Normally the second osteotomy, they say it comes about 4 to 5 centimeter of the distal to the proximal osteotomy. But in the Indian scenario, what I found, there is a very poor regeneration. So where we do the second osteotomy? At the junction of the lower third and the middle third, that is 10 centimeter, 8 to 10 centimeter above from the joint line. So you will get a very good regeneration here. The second osteotomy is like this. So you can see beautifully her Trendelenburg has become negative. She has achieved the full lengthening. How you measure this thing? We measure by the back side by the sacroiliac joints here. When you are doing the lengthening, what are the criteria that you have achieved the full lengthening? Tell the patient and the sign. Second is take the level of the patella. if you have, it will better you take the photographs of the patella and measure that if you have any problem. So what are the criteria? There are two criteria: sacroiliac joint and the level of the patella. By that you know that you have achieved the full lengthening. Okay, clear? You can see it was pre-operative. This is the post-operative. Trendelenburg gate is negative. It was a pre-movie. You can see that there was a shortening and there was a the back lurch over there. It means there was a flexion deformity. You can see that there is a back lurch is there. It means there was a 20 degree of the flexion deformity at the hip. Now, she is walking perfectly. Actually, it was just after post-operative. So you can see the X-ray here. It was a pre-operative, and this is post-operative. What happens when we do the osteotomy? There is a vascular crisis. Crisis means the blood vessels which are going from here, they get blocked there. So the blood supply which is coming to the head and other things, they get more hypertrophied. So they give more blood circulation. So whatever avian and other things is there, that is the, yeah.
Can I interrupt you?
Yeah.
If you look at the first X-ray and last X-ray, there is no so difference where you did the corticotomy, that is the ischial fluorescence.
Yeah.
That one was 50 and 40.
Yeah, yeah.
Okay, in both the ways. So how much angulation you have corrected?
It modifies according to the mechanical pressures, mechanical loading. You are finding the circle is perfect. Initially, whatever angles we make, when they walk, according to mechanical forces, it changes. In the same manner, we don't do much varus in the distal osteotomy. But I find out when they walk, it automatically changes the shape to make it. Yes, sir.
What I do, I measure the angle, say about 45 or 40, and I take a shunt straight, 40 degrees, that much degree, and do the osteotomy and fix up a plate. I don't put ilizarov there, so that my osteotomy is well consolidated and the angle remains perfect. And then I do by ilizarov, I do lengthening of the lower femur.
You do two surgeries. Later on.
One surgery or you can do two surgeries.
You have to. Why to do the two surgery? Number two. Number two. When we can do the percutaneous surgery, why to? For example, you have calculated that we need such a angle, and after that you find. Yeah. Yes. Suppose, for example, and after later on you find during the treatment, during the process, that our angle is not good. So in the ilizarov, we can options to change the angles. And certain thing I tell you, I thought that so that various angles we do not do that, because according to lot of changes comes in the body. So it's a percutaneous osteotomy. We do not disturb the vascularity of the body. We do not open it. Second thing, according lot of changes, I found we have certain angles and the angles change later on according to a body axis. So my recommendation is that, yes, please.
Let me suggest.
Because this is a workshop.
Yes.
This is not conference.
So
you can interrupt
one
me.
suggestion while doing, you selecting the site of the osteotomy and angle, you can select the things pre-operatively by doing adduction X-ray and abduction X-ray.
No, I tell you.
It is a Milch and Milch osteotomy. It is well defined in Dorpele's books. So you select any angle where the femur touches most to the pelvis.
Actually, I tell you what happens.
20 or 30.
Whatever angles you make,
any angle.
whatever angles you make, in the operation theatre, we adduct the thigh, and we take by image, and then we make the arch of the femur, what we apply, according to that. I tell you, you know how we make the angle during the surgery. Do anybody knows that? How we make the angle? What happens during the operation theatre under image intensifiers, we adduct the thigh and then we put our arch perpendicular to the body. So after operations we will get that angle. That is more. Is it clear or not? Because it's very confusing. You give me one bone. Oh, we don't have. For example, this is the thigh and this is the ischial tuberosity. What we do, we will do like this, adduct the thigh during the operation theatre. Okay. When it touches the, this is like this. This is the proximal thigh and this is the ischial tuberosity. So we touch it touches the ischial tuberosity. Now what we do, arch which we will put, its arch will be perpendicular to the body. So then it will give the angle. Whatever calculations you do, that is you make it, but it fails like that. In the operation theatre, you adduct the thigh and whether it touches the ischial tuberosity, and after that you do the perpendicular.
That is correct, sir. The angle that you have measured in the X-ray and in the standing position, that is coincides with this.
Yeah, it changes. Only thing is that you see the patient. Patient is okay, perfect. We have, you can see the photographs, you can see the movie. It means lot of changes takes place later on. So that is the thing there. Okay, this thing is clear. Dr. Bhatia, yeah, how you put the arch, you tell me.
Put the thigh position and take right angle to the arch. We put at right angle to the femur. Long axis.
Arch. And you will adduct the thigh. We will put the, first of all, we will put the screws. Screw should be the right angle of the thigh and the thigh should be in maximum adduction. Shanspring will be perpendicular to the body. That will be. Yeah. Yeah? Yes. Okay. Yeah. You can see that. This is the X-ray. We have put the flange screw perpendicular to the body and we have measured the angle, because if your calculation is wrong, the Trendelenburg gate will not be negative. Number two, perfect lengthening is needed. During the lengthening, there are two places, sacroiliac joints, and take the photograph of the patella and take the pelvis, that, so that will show you the, otherwise it's a young girl. For example, you have done the lengthening, still there is a shortening. The girl will limp there. So when you do this surgery into the young girls, you should be perfect in the ilizarov. What happens? In the ilizarov surgeons, they have operated, still the patient bolta hai, saab bhachak to abhi bhi rahi hai. So you should have the clear-cut biomechanical principles. Okay? You can see that so beautifully the girl is, everything is corrected. Sir, you don't bother for that. You see the movie and you see the patient. That is okay. How I can, so the angle changes, I tell you. You see the movie. Again I will show you the movie, okay? You see the movie. X-rays, it changes according to shape there. You see the movie. There is no Trendelenburg. It's a perfect case.
Can the patient can squat?
Yeah, everything they can squat after some time.
See, when you take a movie, you must see that the patient walks at least 10 feet.
So we don't have a room like.
Walking few steps and then
Sir, we have a studio, and a studio not so big. And if you take the photographs in some corridor or this gives other color. So our studio, now you are telling me we will make a new hospital, we make the studio of the 20 feet. Yeah, so see that. So there is another girl. who is having the poliomyelitis. Very, very difficult case. She was unable to walk. It's a very old case. I think it's about 397. We are about 2,000, 3,000 poliomyelitis. So it or very early cases there. So my Russian friend was there. We have done the osteotomy, applied the arch over here. We have done the lengthening over here. It was arch is there. There were 390 cases there. So very early case. You can see that she is perfect. At that time we couldn't have the movie, so otherwise I have shown you, but it's a perfect case. You can see the X-ray. What is comment here, Dr. Bari?
Yes, sir. This is good.
This is good.
This is good. But that was
This is the ideal case. Well, not that is, you don't think ideal, but that is a clinically perfect.
we don't have any question regarding this, but
Yeah.
that X-ray is showing.
Okay, but the patient is perfect. Yeah. So now you know where to do the osteotomy. I tell you, what happened there, how it works. Actually, this is the limb is adducted. So when they walk, it gives adduction force. For example, this is the ball, this is socket. You need ball and socket for stability. So what he does, we make our force in the abduction. So when they walk, they thrust over here. Because anything needs the stability. That is the basic principle of the ilizarov. So if it is not stable, it goes up and down, up and down. So, Dr. Bhatia, now things are clear. Any confusion? You can, because these are very biomechanically strong, and if you do this thing, all over the patient from India will come you, and you will be the richest man of the India. Yeah.
You will not remove the remnant of the head or not?
Why? We don't touch. We don't touch. No. It gives thrust to the here. Here the force is divided into two portions. One, there is a resultant force is 2. Resultant force is divided into 2. They are the ground reaction vector. So lines come from the ground reaction vector. For example, if you want to thrust this thing, and if you want to have it like this here, so one resonance will be this, and one resonance will be this. Anu is the man of physics, he will tell you. Anu, come. Pardon?
Нет, я никогда не.
We do this arthritis in the girdle stone. When the head is there, why you shall touch that head? Yeah, forces. Yeah? Pardon? He will tell you that. इसको बता रहा है. Back to कर लिया इसको. He is the man of the physics.
Создает дополнительную точку опоры, да?
How this forces work? अरे ये force कैसे काम करता है? चलता है. मालूम है?
А он, получается, стомировал, а потом снизу линию.
He is the man of the physics. He is a PhD. He is the professor. Physics working for how these forces work.
Actually,
Mike.
when we move, our divided into two forces. 145 force is 45 degree angle.
Mike.
The when force is 45 degree, there are two components, horizontal and vertical. So one along GRB line, this one, and another is a vertical, this plane. So when we move like this one, our vertical force balance with the GRB line. So that's we balance. Our load and GRB line and the force vector both are aligned, like this one. So that we still on the ground.
They are not very clear about the biomechanics. You tell how these forces. Ground reaction.
That's a subject of a one-day conference.
Actually, GRB line and our body force, when aligned with each other, then we body balance.
Okay.
Подвертильная, да?
Now there is another boy. Yeah.
Чуть ниже бы вертел, получается.
How?
Все остаются где? То есть мало
No, I tell you, I make the bed like that. So there are blocks are there in the beds. So when they lie down, their knee is lie down. We make a certain blocks in our bed. So we remove that below the knee blocks. So they have the flexion like this. They can move like this. So we make a special beds in our hospital. So whenever you want, you can move that. And for example, the patient 90 they can do anything. No, they can do anything because the whole, they put some pillows there, some blocks are there, and they are moving there. That is done by, you have to make the blocks of that. Okay? We made a special beds for that.
If you go for lengthening the lower femur more than 5 centimeters,
Yeah.
you will get stiffness in the oblique.
So you put into the flexion position sometimes in the night. So there will be no problem, I tell you, in all those cases. Initially we were very much worried about the stiffness of the knee, but now we have done that. Now this is another case. I think it's a old pathology or something. I think so, or we don't know very much. But he was having Trendelenburg gait. So we applied this pelvic osteotomy, abduction osteotomy. We have done basically, this is a abduction or pelvic support, whatever you say. And second lengthening we have done a lower down at the junction of the upper middle third and lower third. You can say that it is a very beautifully, the head is vascularized there. Is another case who is having the old dislocation hip, about 5 centimeters shortening. So we applied this frame. We have then osteotomy and the lengthening was there. The whole thing has been achieved nicely. So before surgery, it was after surgery. It's a perfect lengthening. When you do this lengthening, please do the perfect lengthening. It is another case, I think it's an old non-union, I think perhaps. Dr. S.N. Agrawal was telling me, where is Dr. S.N. Agrawal? He was telling me in the old cases of the fractured neck femur, which we usually get in our scenario. So we have done, we applied the frame. This is the configuration, 2 arch, 1 arch, 1 ring. You can see that we have done the abduction osteotomy at the level of the intertrochanteric region, so that 3 fragments, head, greater trochanter and the distal femur, they make all 3. So it's a perfect. You can see that. Are you agree with that? Old fractured neck femur in which we do the prosthesis at total hip, other things. For those cases, Dr. Bhatia, do you agree with that? Arthroplasty. So, yeah. Intra-articular. So, abduction osteotomy is something. So, it's a vertically. In the old cases of, yeah. It's abduction osteotomy basically. Yeah. Anyhow, our main aim is that this fragment, you know, here, we have put this fragment into the head. This is the greater trochanter and this is the head. So these all 3 has united and the patient has become, otherwise we would have done that at this so young age, the prosthesis are total hip. So if you want to save, and he is having I am following this case for last 10-15 years, it's okay, there is no problem.
This is, here you can see a fibrous and callosis.
Like that, controlled, like McMurray. Yeah, but it's a controlled. But it's a control, I think so. Control McMurray, okay, sir. This is another girl, Trendelenburg gait positive. She was old, I think, Parthis or even, sir, what will be your diagnosis? I'm very always confused. What will be old? It's about 18 years girl. Old septic arthritis. It's a old septic arthritis. There was movements less, painful for that. Dr. Agarwal, what will be your diagnosis in this case? Old septic arthritis, okay? So what you will do? 23 years girl.
I will open the joint, I will do the girdle stone.
Girdle stone, okay.
Then interval period for 1 month at least,
Yeah.
with little bit physiotherapy.
And then,
Then ilizarov.
what ilizarov?
Means we'll calculate the angle and make a new joint like hip reconstruction after that and lengthening on lower end.
What you will do the hip reconstruction?
We'll pass 2 screw in
Mic on karo. माइक ऑन करो यार, कहाँ गए हो? अरे माइक ऑन करो.
जरा ऑन कर देना भैया. ऑन है सर, ऑन है. So first we will do the girdle stone.
First surgery will be
The girdle stone.
girdle stone.
Yes sir.
And
Then on traction we leave the patient for 1 month at least.
3 months, Mr. Minimum.
Maybe.
3 months.
Then with physiotherapy and later on we will do this ilizarov fixation in one sitting. On upper end we will do the osteotomy and we select the label after doing few x-rays. That is what I follow.
Dr. Sahu, Doctor, what you will this in this case? Yeah, tell me this case. Old septic arthritis hip.
This case, I am Dr. Sanjay Das.
Sanjay Das.
In this case, this is a old septic arthritis, old Smiths, I believe.
24 years girl.